So there's, also, my patients or Dr. Bak's patient is very knowledgeable on ventilator. So there's CPAP and BiPAP. When we, go to the hospital, you hear that, some patient on CPAP, some patient on BiPAP. Actually, we don't agree to give a CPAP because CPAP is continuous positive pressure. So for you to breathe, because your lung is continuously collapsing because you are very weak, so we want to give positive pressure to open it. So if you give a very high positive pressure all day long, your lung can be opened, but it doesn't follow the normal breathing pattern. Because when we breathe in and out, there's pressure difference, right? So this CPAP works as a splint. You put the splint and open itself all day long. It doesn't go lower and higher. So we want to move to BiPAP, which is bilevel positive airway pressure. So you can tolerate when you expirate. So there is an inspiratory, expiratory pressure difference. So it simulates the normal breathing patterns. So I think this span, the concept on span is very important. This span. I don't know how many people heard about span. Yeah, span is like, I had the same experience because a pulmonologist doesn't trust the rehabilitation doctor. You are only rehab doctor. So when I claim, they say, you are rehabilitation doctor. Okay, so we went to same medical school. But anyway, I had one patient who had, she was SMA 3. After the hospital admission, she was transferred to the rehabilitation floor, and she only needed BiPAP at night. That was her baseline. And then she constantly putting her mask back during the day after the therapy. I said, why you keep putting your mask? She said, I cannot breathe. I need it. She was very anxious. So I took a look at her pressure. The span was 9. It was not 10 even, more than 10. So I called the pulmonary as a courtesy because I have to call them. It's under their care. And they were so busy. So I talked to them, why don't I increase the span to support their respiratory aid? Actually, they said, oh, that's not a bad idea. So I increased the 12. The span became 12. And the patient, the symptoms all gone. So she was able to participate in therapy without any problems. So she needed to have a little more support. And then this is BiPAP, very small. I think the reason why I put the SMA case here, I was thinking it's similar with the infantile form of Pompe, so I added this one. So initially we don't know, even SMA, some cases at birth we don't know at all. But the patient keep having pneumonia. We don't know the reason, but some point we are not able to take the ventilator off the patient. And then they start to show paradoxical breathing. So when they breathe in, it doesn't show very well, but the chest goes inside. It should come out, but chest goes inside. So I don't know whether you guys saw those cases, but their chest are all depressed. We call them pectus deformities. But all the patients under Dr. Bak, actually, they don't have those kind of problems. Look at these two brothers from one family. Here, they are 6.5 and 4 years old. They are SMA 1, Worden-Hoffmann type, which means they're never going to walk, they're never going to sit by themselves. But they go to school, and they breathe with BiPAP. As soon as they were found to be SMA 1, Dr. Bak put the BiPAP. And they go to school with BiPAP, so they have no chest deformity at all, and they're very happy, and family loves them. I just made a phone call to Dr. Bak to make sure how they are doing. Actually, they're still very healthy. They're like 10 years old. One, I think, older one is 10 years old. The other one is younger. They're all healthy at this point. And then this lady was referred by insurance company to Dr. Bak's office. So many people actually, not physician referring the patient, actually insurance company referred the patient to him because many patients, they complain. They say, I don't want to have this trach forever. And then the physician goes, you need that because that's your lifesaver. So they don't close. And by insurance company, they know who is good. So they usually coming from other states. So this lady had some myopathy, and she needed to have a trach, but now she doesn't need it. So she wants to close, but no doctors agreed to close. So she came all the way from other state to the, Dr. Bak's office, and he had to close. That's what his business is. He always helping patients, but not doctors. So now this is what we are doing, non-invasive ventilatory care. But there's some 5 different parameters I want you to do. I don't know, whenever patient goes to the clinic, Dr. Box clinic, my clinic, we have respiratory therapist. So we are checking the vital capacity, maximum insufflation capacity, peak of flow meter, and the tidal CO2, O2. So whenever you come to the clinic, you sit down like this. We put the prong here. We put the pulse oximeter here. So we are measuring the CO2 and oxygen level as soon as they are coming to the office. And then let them sit quietly. So we have a baseline number. And then we check same things with the lying position. So vital capacity is the capacity when you can breathe in very hard at once, and then the way you can breathe out. So, and then you're going to use a spirometer. Usually, adult is about 6 to 7 liters per second. But the muscular dystrophy patient, as they get weaker, the number goes down. Some patients is less than 1 liter. Usually, we start to give a ventilator. The vital capacity less than 50% of their ideal vital capacity. So as you see, with the sitting posture, with the lying posture, we are measuring. And normally, when we are born, the newborn is only 100 cc capacity we have it. But later, when we become like mature, the lung become mature, it's usually 6,000 milliliter. So same air stacking exercise. Did you guys learn air stacking exercise? Yeah. So I brought the Ambu bag. Actually, if you want to try later, you can try. But we can do air stacking exercise with ventilator because we are giving the pressure at volume. But you can also use frog breathing. So Dr. Bach really asked me, you have to teach that frog breathing when you are there. So I have to do it. And then he's going to send the video to him, so make sure evidence-based teaching. So everybody ready? Yeah. I have to, otherwise he's going to fire me. Okay. So you have to, the one gulp usually brings 60 milliliter of air into your lung. And then you have to close your glottis. And then you have to add another air until you can tolerate. So, and then don't breathe out. Can you feel it? Feel that your chest is expanding? I'm having headache now. I have to confess I don't do this exercise that much. But this is very important. Let's say electricity is not available. That can happen, right? And then we can do ventilatory support without the electricity if you know how to do frog breathing. So if you can do this exercise 3 to 4 times a day, that is long range of motion. Because I'm a rehabilitation doctor, so my patient, they have to do joint range of motion, right? If they get tight. You guys, same things. But we also can do long range of motion. Chest PT, this morning some physician was talking about chest PT. That doesn't work that much because you guys don't have a lung disorder, right? You don't need a chest PT that move that much. But, sorry, everybody wake up.